we get these reports, and a lot of times other specialties may also get the reports, their primaries, and it may list 5, 6, 7 things, and that doctor just assumes, okay, those are all their injuries.
Of course, yeah.
Well, a lot of times there are changes that happen to our body as we get older, and some pathology you see on an MRI may have nothing to do with their actual injury. So you have to kind of tease that out a little bit.
Today we have on the show Dr. Mark Schwartz. He's an orthopedic surgeon. Welcome to the show, Dr. Schwartz.
Thanks for having me.
Yeah, so you're an board-certified orthopedic surgeon, right?
Correct.
What does that really mean?
Well, board certification just means that you go through this rigorous process of testing. So once you graduate, you do a residency, and then you got to take multiple steps of tests, and then you got to maintain that board certification every few years by doing certain hurdles that you got to go through.
Gotcha. So that takes some years to get to.
Takes a lot of years, yes.
And first of all, you have to go to a 4-year college, right?
That's a 4-year college, followed by 4 years of med school, followed usually by 5 years of residency. Many of us then do another year of specialty training.
Is that a fellowship?
A fellowship, right? And then you get into practice, and then you start off as a junior doctor and work your way up.
So how many years of training do you think you had before you were kind of out on your own after college?
After college, so it's 10 years, I would say.
10 years of training.
10 years of training.
Wow. Did you feel?
I'm not making that much money at
Oh,
all.
no, I know. A lot of time, right?
Right. A lot of time, yes.
Wow.
And when you're a junior resident, once upon a time, we were doing 100 hours a week, and then they passed some rules that you're not allowed to do more than certain hours.
Wow.
Well, so when I was a junior resident, we were doing hour upon hour upon hour. Then when I was right in the middle of my residency, they changed the rules.
Yeah.
So all the junior residents got to go home. So us as the senior residents had to now pick up more slack that normally they didn't do. So,
wow. So with all that training, like, did you feel comfortable and you felt like you had the skills to kind of go out on your own at that point?
Yes, at the end of all that training, yes. But still, like when you're in the operating room and you're in training, there's always somebody else there.
Yeah.
And then once you get out on your own, you look around and nobody else is there. Yeah. You don't realize what that other person's always doing. So now I'm doing that. There's others where I'm training others. We work with residents, and you'll just kind of move this here, move that there, and they don't realize you're doing that. But then when you're by yourself and you're on your own, you're like, how come it was so easy last time?
Yeah. So you kind of provide a level of comfort too for the junior surgeons. So, yeah. Wow. So we don't have that in the law. That's the crazy part. We graduate from law school with these, ideas of weird topics like real estate and property law and criminal law and torts, which is another name for like personal injury in our real world. But there's no fellowships. There is, like, hopefully you get to a firm, and it's actually the senior lawyer's job to kind of oversee the junior lawyer
their way
to some degree, but it's not official like that.
So you may not get that in every law firm. It may be
you're allowed to go out on your own.
Right.
Like, and they actually, in third-year law school, they'll have law students actually doing clinics and stuff for free, like for impoverished people, things like that, just to kind of get people experience, even though they didn't even pass the bar yet. So it's a little bit different, yeah. So it's interesting. But I know some lawyers that as soon as they left law school, they go out and start their own business
practice
without any experience, which is
they usually have like parents in the field or something.
Some of them just go out on their own because they're just like maybe they didn't have all A's in law school or top 10% or whatever, or dean's list,
right?
So nobody maybe wanted to hire them, whatever. Who knows? That some people just want to go out and hang their own shingle. It's crazy like that. But anyway. Can you tell our audience, like, what does an orthopedic surgeon do?
So orthopedics, I mean, there's multiple specialties even within orthopedics, but in general, orthopedics is a doctor of bones and joints. We take care of both injuries and chronic musculoskeletal problems. That's the big picture. We're surgeons, so we do fix a lot of things or treat a lot of things with surgery.
And do you have specialties in that field?
Yeah, there's a lot of specialties. Me particular, sports medicine, which has become somewhat of general orthopedics, but my particular specialty, I do a lot of knees and shoulders.
Knees and shoulders, okay. And how long have you been operating on knees and shoulders now?
Good question. How old am I now? It's probably been about 20 years.
20 years. Okay. Wow. A lot of operations.
A lot of operations. Yes.
Wow. So now you're working with HealthBridge Multispecialty Group, right?
Correct.
Can you tell us a little bit about HealthBridge?
So HealthBridge, for years, I don't know how long, was pretty much strictly a chiropractic group. Within the last year, they've expanded and they brought me on as the orthopedic wing or musculoskeletal wing. And there's another physician who's part of the practice as well, Dr. Gradovsky, who, as a pain management doctor, sees a lot of our spine.
Okay. And do you see spine patients too, or just?
I don't see any spine. Pretty much everything extremities.
Mostly joints. Yeah.
Mostly joints, really from the shoulders down to the fingers and the hips down to the toes.
So when people come to the multi-specialty group, what type of conditions are they generally coming in that you're seeing now at the new firm?
So, it's mostly injuries. It's people who've been injured. I mean, that's what orthopedics is. Everybody's getting injured. So a lot of what we're doing is injuries, personal injury, slip and falls, car accidents, and a lot of workers' comp type injuries as well.
So mostly wrists, elbows, knees.
To be honest, probably the most common. Well, you get a lot of spine injuries and a lot of knees and shoulders, which is kind of right on my alley. So.
Gotcha. And mostly all different things. I guess a lot of people injure their knees in car accidents, right? So they have something called dashboard knee. Have you heard of that?
Yeah. Well, I've never heard of that specific term, but I know that the dashboard does cause a lot of injuries. A lot of times, if it's a high enough energy, people can tear their PCL because the knee hits against the dashboard and the rest of the tibia goes backwards.
Yeah, so I guess it's more of a frontal impact where the body goes forward and the kneecap hits the dashboard.
Right, and the rest of the knee goes backwards.
Causes sometimes fractures, right?
Patella fractures, yeah.
They're paid for it.
Yes.
I've had some clients with them over the years, yeah. So you actually do so a lot of orthopedic surgeons are, that I see, it's kind of like heart specialty where some are they're just consulting. They'll just check on people and kind of refer them to the specialist, while others operate. Where do you see yourself?
I would say most orthopedic surgeons, unless they're kind of getting ready to retire, still do operate. There are a lot of non-operative musculoskeletal doctors. They tend not to be orthopedic surgeons.
Like a physiatrist or something?
Physiatrist, exactly. So they'll see a lot of the musculoskeletal injuries and then send them to us. Yeah. But most orthopods, they're still cutting. They're still cutting. Yeah. Exactly.
Awesome. So so if somebody comes into HealthBridge Multispecialty Group, what's their experience like? Like who do they see first? Or sometimes they refer right to you? Or do they see somebody else first? How does it usually work?
It's kind of really all over the place. A lot of times they do come straight to us. In the workers' comp world, they get injured. A lot of times they got to go through the whole panel. Then they get shuttled to different doctors and eventually maybe make their way to me. I'm actually on the panels now as well. So I'll be seeing a lot of the frontline injuries, and then a lot of them that are, contesting various aspects of their case.
Both sides of the fence.
Both sides of the fence, exactly.
So when somebody comes and sees you, they make an appointment, obviously, and they come in, and what do you do? Do you do a question session where you find out information, like take a history?
Sure.
Tell us what the appointment, the first appointment.
That's pretty much any orthopedic or really any medical visit. Patient's going to come in and they're going to give you their whole story and tell you exactly how they were injured. And that's important for orthopedics because we try to conceptualize exactly how the mechanism was that injured them, and that helps us predict what the injuries are going to be. Yeah. So when patients come in, a lot of times they've already seen somebody else, whether it's their primary care physician or maybe a physical medicine and rehab doctor,
maybe the hospital,
physical therapist, or in an ER. And a lot of times they have imaging already, which we like. So we could get as much information as possible and put it all together. So when they come in the first time and they don't have anything, we have to really send them out for X-rays, MRIs, whatever it may be.
Do you suggest new patients come with their discs, with their X-rays or MRIs, things like that, or do you have access to that?
So yeah, 100%. We like them to have their discs. However, in today's world, those discs take forever to load up. So I have access to most places to look at it up online.
Yeah.
Because if you have to do it with the disc, you're sitting there 15 minutes while the thing is spinning. It's spinning, and half the times it doesn't even open.
So are hospitals, and I guess the medical field in general, getting better with being able to share that if you have the proper HIPAA forms or things like that, credentials?
So, it's funny because almost every place that a patient goes, they ask, hey, can I have my imaging? And a lot of times the places tell them, oh, we'll send it over to your doctor.
Yeah.
What they really mean is they're sending the report.
Yeah.
Most physicians, that's fine. But orthopedics, we look at our own films because, radiologists are great, but sometimes we're examining the patient and we see something different than what the radiologist who doesn't know any history about the patient.
We see that a lot as personal injury lawyers.
Yep.
A radiologist sometimes misses things, sometimes doesn't point out specific things.
Correct.
Right? And then you as an orthopedic surgeon do your examination, you determine the mechanism of injury like you were telling, right? And then you're able to actually touch the person, push on things, right? Do some
which makes a huge difference. I mean, in all fairness to the radiologist, they just get a picture in front of them. They have no idea really any of the history.
Yeah,
so it's important to know that history and then take that and look at the films and then go from there.
It's good to know what you're looking for.
Correct.
Right? And then that's why I've always thought a treating physician, whether it be a spine surgeon, an orthopedic surgeon, their reading of the films, the MRIs, the X-rays or CAT scans, whatever, I always give that more credit.
It's more important. Just we get these reports, and a lot of times other specialties may also get the reports, their primaries, and it may list 5, 6, 7 things, and that doctor just assumes, okay, those are all their injuries.
Of course, yeah.
Well, a lot of times there are changes that happen to our body as we get older. And some pathology you see on an MRI may have nothing to do with their actual injury. So you have to kind of tease that out a little bit.
Yeah, so you're kind of fine-tuning that diagnosis, or at least that finding on the MRI or something like that, based on your more better information. You actually talk to the patient.
Correct.
You examined him or her. You kind of put your hands on them, and now we know what caused it and where it's at.
Correct.
So what about have you seen any? We hear about it in the news and about AI coming into radiology and kind of looking at scans before the doctors even see them. Have you seen any of that in your field yet?
AI's rapidly coming into our society. In medicine, I personally haven't seen a lot of it. I do feel bad for radiologists because I feel like that field is going to disappear when
I think instead of having like what a typical medium-sized small hospital, how many radiologists they usually have?
They probably have 5 to 10 on staff, but not working at
not all the time. So I'm thinking maybe that 5 to 10 go to like 2 or 3 because they have AI, right? And then a lot of them probably ship them overseas to take a look at, right?
Yeah. So I think a lot of like the overnight MRIs and X-rays that then an ER is going to do.
Yeah.
There may be a guy in Australia sitting on his boat reading those. But that's going to become an AI computer doing that.
Yeah, it's crazy how it's changing. Well, it's hopefully changing medicine for the better.
I think so.
Making things more accurate.
I think so. It could take so much information and just put it together and spit it out within a second. So for making differential diagnoses, I think
that's really good because we see it in the law. Just analyzing a doctor's report versus a doctor's report.
Right.
What are the differences? What are the key differences? What are the proofs? We use it in our practice as much as we possibly can to help. But it's almost like something that's going to do the first draft. We still need to be there to check it.
Still need to overlook it.
But as an orthopedic surgeon, I think at this point, unless robotics really come into play, you still need to be with the patient.
Right.
People
100%.
still need to meet with a live person, I think, for at least a long time, to hear them, to touch them.
I think that's the key. It's the physical exam. There's a saying in medicine, something like 95% of diagnoses can be made just by a history and physical without any
testing.
Exactly.
Yeah.
So, you're right. Unless computers are examining patients and then operating on patients, it's important, especially in orthopedics, for the doctor to be there.
Yeah. I mean, even I have a good friend that's a spine surgeon, and he always says, I don't need an EMG test. I know what to feel and what test to do.
Correct.
That's just confirming
it.
And it's really just there because really either insurance companies or lawyers or other people want to make sure that it's there.
Correct. And you want to make sure there's not other things going on that may complicate the planned surgery.
Yeah, absolutely. So just make it more accurate. But I'm hoping it's going to make medicine in general more accurate. Obviously, it's going to take some jobs away. But same thing with the law. We will be hopefully more accurate. We won't miss things. Like, I can upload 1,000 pages of medical records and do a summary in like 3 minutes.
Right.
I can analyze the whole case. Say that one case I have with 25 depositions, and ask it 3 questions, and within 30 seconds, it's the most accurate, detailed thing I've ever seen. I couldn't pay an associate 40 hours to do that. Right. So it's hopefully making us more
precedent than things in previous cases.
Yeah, that's a little tricky right now, the case stuff, because they're now starting to merge case systems, research systems into certain AI platforms. But for me, it's just like in litigation, I pick different documents and just have them analyze it, or find me this, or in 1,000 pages, find me all the instances of ADD in a child or something, and it spits out a 25-page report with every reference, everything you can think of in seconds. Yeah. So it's interesting in that department. So yeah, so shoulders and knees are your main specialty, right? Correct. Let's talk about that. So shoulders involve a lot of different parts, can we say, right?
Correct.
There's bones, tendons, ligaments, right?
So yeah, first of all, one of the big things, and this is what we see a lot in orthopedics, is differentiating true shoulder pain coming from the shoulder joint versus a radiating pain from the neck. And a lot of people will say, oh, my shoulder hurts, but it's really a neck injury and they're feeling radiating pain.
Nerve injury, mostly.
Nerve injury, correct. It's like a radiculopathy. So we have to get that out of the way, and then we could examine and identify the actual shoulder injury. But yes, it involves your bones, the joint, which has cartilage in it, and then a lot of soft tissue.
Shoulders seem to be really tricky to me as a non-medical doctor, because you have so many nerves coming through the shoulder area, the brachial plexus, right?
Correct. Yep.
Right in the same area.
Yep.
There's so many bones coming together. There's so many different ligaments and tendons, and it all has to work together.
And it's a free joint. It's not like the knee's a hinge. It's just really going back and forth.
It's a capsule, and there's a rotator cuff.
Correct.
Which we hear about being injured a lot, and there's just so much going on in there that,
I guess it could be complicated.
Yeah,
but
it seems to me to be.
The more you do it, you can easily identify what.
I guess like certain. Again, back to the mechanism of injury.
Correct.
Certain falls, certain sports injuries, whatever the sport may be. Based on that, there's probably 4, 5, or 6 different injuries that likely come from somebody falling and planting their hands on the ground to.
Yeah, I mean, you have which direction the force went. So in that direction, they may dislocate their shoulder posteriorly. They may jam the shoulder, tear the labrum.
Yeah.
Certain falls with your arm up and out like this, you'll dislocate it forward.
Yeah.
And then we know, just based on statistics, younger people, for example, a dislocated shoulder, younger people, 25 and under, they're going to tear their labrum. Older people, 40 and over, they're going to tear their rotator cuff with the same mechanism of injury. So we kind of know what to look for, and then what to test, and then we correlate that with the imaging.
So it's I always say, people come to us and are like, what's our case worth in the first week? And we're like, well, it's like a 1,000-piece puzzle.
Right.
And I just have like 6 pieces right now.
Right.
And it seems to me like that's kind of what you're doing. You're putting all the pieces of the puzzle together to come up with the most appropriate diagnosis.
And then treatment.
And then recommend treatment for that, right? So I think with orthopedists, in my experience, physical therapy is probably the number one or first treatment for most things.
For most things. I mean, look, you fall and you break your hip, you're not sending the patient to physical
Fractures
therapy.
are different.
Yeah, fractures are different. So, but most soft tissue injuries, it's always a good place to start with some physical therapy, modified activity and time. The body really does have an amazing potential to heal itself.
Even the shoulder does, I think. I mean, I've been lifting weights since high school, right? And there's been times I haven't lifted as much when I had kids that were young and I couldn't get to the gym. But I remember about 4 or 5 years ago, all of a sudden, I think it was just because I'm a stomach sleeper and my arm was up like this, and eventually caused some kind of strain or tear, and I couldn't even lift 20 pounds up over like press like this. And I was concerned, and I know how painful shoulder surgeries are. I mean, everyone tells me it's one of the most painful surgeries out there.
It is.
The rehab,
the rehab, and most people after shoulder injury as well, but even after shoulder surgery, they can't lie down flat 4 weeks.
That's troublesome for a lot of
You're in
people.
a sling. It's tough.
But magically, I don't know why or when, it started to go away.
A lot of that's the inflammation. Once the inflammation starts coming down and then you get your motion back and you're kind of breaking through any scar tissue, a lot of times your symptoms go away.
Cleans it up. Yeah. You got to deal with inflammation on top of all these parts in the shoulder.
Yes.
Well, so, shoulders and then knees. Knees are a little more simple, or no? How would you say?
Yes and no. I mean, I think both joints are incredibly complex. They're just complex in their own sort of way. For me, any shoulder or knee injury, look, they're always complicated. There's always things that you'll experience that, I've never seen that before.
Yeah.
But for the most part.
But the problem with the knee, you're weight bearing, right, compared to the shoulder.
Correct.
So you're taking on more strain, even after the injury.
Correct.
Shall we say? So that it becomes just as symptomatic as the shoulder, if not more.
Yes.
Right. Wow. So what other types of therapies or treatment do you recommend after a knee injury or a shoulder injury? Like tell our
so I mean, obviously a lot is going to depend on what the diagnosis is, but yes, typically we like to be conservative when we start. So that entails physical therapy, modified activity. If you may want to immobilize a joint. If it's a knee, you may take them off their feet. And then there's different modalities that they could do in the physical therapy world: ultrasound, electric stim. And then there's injections that we often do. There's cortisone, which we're starting to move away from. Cortisone has its own negative effects. It's a powerful medicine, and it really helps, but it has a lot of negative side effects too. So there's different injections in the knee. You have viscosupplementation. It's kind of interesting. Only in America, it's only the knee that you could do that. In other countries, you could do it in multiple joints. Really? And then the big thing lately has been PRP. Which is a healthy alternative to a lot of these.
That's platelet-rich
plasma.
Yeah. And that's like what, spun blood?
So basically, you draw your blood and you put it in a centrifuge, and the platelets, the plasma goes one way, the blood cells go the other way, and then you draw up just the plasma and you inject that back in, with the goal of stimulating a healing cascade. Our platelets are part of that process.
Gotcha. What about like stem cells? I hear about them too.
Stem cells is also kind of one of those new fields. There's very little standardization right now. So there's different companies making different preparations. So the studies are really all over the place.
And I think I hear about all these new medicines coming out with AI, and then there's the CRISPR stuff that they're coming out with, different types of modalities and stuff. But then, I think it was on 60 Minutes this week, it's the insurance companies still finding this experimental.
Yep.
And
that's the problem. You get all these studies, right, that are all over the place, and you may get a bunch of studies that doesn't show the results that you want. They're not negative results, but just not the extent of positive results. Yeah. So insurance companies won't pay for them.
Yeah. And the newer drugs or treatments are super expensive.
Correct.
And they can't afford it. They were saying this is a health problem because there's all these new things coming in with new science, and it's going to take time for the whole system to be able to absorb these new costs.
You have the whole functional medicine aspect of things now as well. So.
Yeah. Tell us about the functional medicine.
I don't delve much into it. Actually, my wife is getting into it a little bit. She's a nurse practitioner.
Okay.
But it's taking a little bit of a different look at medicine and how it's treated. Instead of just the classic medicines, you're trying to use more natural remedies.
That kind of thing, yeah. There's just so many different ways to attack an injury.
Correct.
Over in, the East, right? Japan and China, they have a whole different medical system, right? And we're historically based on drugs, at least in the 1900s, right?
So I think maybe a lot of that came from financial incentives.
Absolutely.
So I think the reality of it is it's probably a combination of everything.
Yeah.
It should never be just, all right, we're only treating it this way or you're only treating it that way. It's probably combining everything.
I mean, like back in the Prohibition age, they used to use bourbon to treat a lot of stuff, I heard. So I try to do that on the weekend.
There you go.
Yes. So where do you see this orthopedic surgery field going in the next 5 years, 10 years? I mean, you have some good years ahead of you.
I do hope so.
Yeah.
Where do I see it going? I think it just advances in both our techniques, but then a lot of the implants that we use, they're getting smaller, they're less reactive to the body. We put a lot of metal in the body and a lot of certain plastics, and the more we could get away from things that are causing secondary reactions, the better we're going to be. Less invasive surgeries. We used to make huge incisions. Now we're making smaller and smaller incisions.
It seems like medicine like that is becoming so advanced. It's about minimizing future risk, minimizing, like you said, complications or side effects of what is done.
Yeah. Side effects and just getting people better quicker with less collateral damage, I guess.
Yeah, like I noticed it. Like my son had leukemia when he was 3, and he had ALL, which is the most common treatable form. Back in the 1960s, it was like a 2% survival rate. Now it's over 90%, right? So he was put in studies, and he's doing great now.
That's awesome.
He's one of the wrestlers in 9th grade. So strong, healthy, thank God. But he was put in, there was multiple studies they were doing down at CHOP, which is one of the greatest places around.
Sure.
And there were different studies on how to reduce the amount of medicine and the type of different medicines to make it less toxic on them, so that they didn't have any nerve issues when they got older, especially as teenagers. I
think you saw that a lot of old cancer treatments used medicines that caused cancers when they got older. So to try to avoid that, and just back to orthopedics, like once upon a time we would do an ACL reconstruction, we'd park you in the hospital for a week afterward. We'd put a cast on your leg and you wouldn't walk on it. Nowadays it's outpatient surgery, you're walking on it right away and you're moving it right away. So that's a lot of research goes into, hey, well, we want to be conservative and not allow something to heal, but we found that doing more oftentimes helps. It's actually swinging back the other way now. They're seeing, well, maybe we should not be as aggressive because it's causing more inflammation. So it's just this pendulum that goes back and forth.
Yeah, like I heard, I know my partner had a hip replacement a couple of years. He was on his feet the same day.
Yep. You get him up and walking on it right away.
No, my mother-in-law had a knee replacement surgery, a partial, and that was painful. She had to walk a lot.
Typically, knee replacements are more painful than hip replacements.
Yeah.
I can't tell you exactly why, but
you push through it.
Almost to a T, a patient will tell you, oh yeah, my hip replacement was a breeze. The knee was much more difficult.
Yeah, well, maybe medicine will be better in the future. Yeah. So HealthBridge Multispecialty Group, you are now the what do you call yourself? The chief of orthopedics?
I'm the chief of orthopedics. I'm also the only orthopedic doc there.
All right. So you are seeing patients in many different locations? How is it?
So my main location is in Bala Cynwyd.
Okay.
I'm there 3 days a week, but that may go down to 2 days a week because I think I'm going to see patients up in the Northeast as well.
Northeast Philly?
Northeast Philly.
Okay.
Yeah, the Feasterville area.
Okay, it's near here.
Yeah, exactly. And then once a week, I go to a satellite office. So I go to Allentown. Essentially, it becomes once a month. I go to Allentown. Once a month, I go to Reading. Once a month, I go downtown Broad Street, and once a month, I am in Lancaster.
So you're covering, just about the southeast corner of Pennsylvania.
Yeah.
Right? Okay. And
put a lot of miles on my car.
Are you able to see patients like telemedicine wise, or do you always have to put your hands on them and do some orthopedic tests?
In orthopedics, kind of like what we were saying before, if you don't have the ability to put your hands on a patient, you're only getting half the picture. It's like going to a cardiologist and he doesn't have a stethoscope. You can only do so much without that physical exam.
I'm sure there's some different types, like definitely psychology and psychiatry.
Sure.
You don't have to be there in person.
Yep.
Orthopedics is one of those.
Even Chinese medicine, yes, you maybe want to listen to their lungs or whatnot if somebody's sick, but for the most part, you could do a lot over the phone. Orthopedics, it's a little more difficult.
Yeah, so great. Well, thanks for coming on today. I mean, how can our audience find you? Is there a way? Was the best way to contact you, or through the specialty group? Or
I think we're on all sorts of social media to get our contact information.
You're just a good doctor.
I'm just the doctor.
You're working hard.
I let other people handle all that stuff.
You're working hard and doing your job, and they handle that.
Exactly.
But great. Well, congratulations on the new move.
I appreciate it.
Thanks for coming in.
Appreciate it.
Love to you.
Yep. All right. Thanks.